This is part 3. My name is Clara. I'm one of the neurology residents here at Langford, and today I'm going to talk to you about seizures. What could be causing a seizure? So we generally divide seizures into extracranial or intracranial in course. Your extracranial causes are basically your metabolic or toxic disturbances, such as hypoglycemia, hepatic or renal dysfunction, hypothyroidism, exposure to toxins such as carbamates, organophosphates, lead poisoning, ethynyl glycol, metaldehyde, strychnine, or chocolate toxicity, for example. The list goes on. And then on the other hand, we've got our intracranial causes, which are your functional idiopathic epilepsy, as well as your structural disease, which can actually be a number of things from developmental abnormalities to tumors, infectious or inflammatory disease, and then vascular and traumatic brain disease. So what are the causes of seizures? I guess there is some blood work you want to start doing in your patients. A hematology is going to be useful to maybe assess your PAC cell volume. And then your biochemistry is going to be useful to evaluate your electrolytes, your liver enzymes. And if you can do an ammonia, that would be quite helpful as well. And then your kidney parameters to assess kidney perfusion. It's important that the dog has been fasted, and if the animal has not been fasted and it's not an emergency scenario, I would suggest you ask the owners to bring the animal back when a prolonged period of starvation, so usually throughout the night, has taken place, so that you can do your blood tests. I guess if your blood glucose is found low, there is a few things to consider. It might be spurious, and you might want to do an in-house blood glucose check with a glucometer, for example, as if you wait to send it to the lab, these can falsely decrease over time. And if it's still low, then you might want to do a serial glucose curve, which is also quite useful to understand what's going on, particularly to rule out conditions such as insulinomas in older patients, or hepatic encephalopathies associated with congenital or acquired postsystemic shunts. In the latter, other abnormalities to consider include hypoalbuminemia, reduced urea nitrogen, hypocholesterolemia, a mild increase of liver enzymes. But what you most often tend to get is a raised bile acid stimulation test and an elevated ammonia. In kittens with FIP, you may occasionally observe other things such as an inflammatory leukogram, maybe a albumin to globulin low ratio, or an elevated bilirubin, although these changes are reportedly not always consistent. It is worth mentioning that mild biochemical discrepancies can occur after a seizure, so bear that in mind. Because of hypertension, hypoxia, you can have mild increase of liver enzymes, as well as other electrolyte abnormalities, okay? So once you've ruled out your reactive, or let's say extracranial causes, right, we put that to the side. Let's go into the intracranial causes. So only on the occasion where there is a structural brain disease that has affected silent areas of the brain, you can actually have normal blood work and a normal neurological exam. So these are lesions in the olfactory, occipital, or piriform lobe, for example. But generally with a structural brain disease, you tend to see signs. If there are forebrain signs, you get augmentation, circling towards the side of the lesion, for example, posture reaction deficits, or cranial nerve abnormalities as well, in terms of animals with, let's say, brainstem conditions, as well as forebrain disease, okay? So the diagnosis of idiopathic epilepsy is one of exclusion and is based on the following criteria, which is a bit flexible, but usually what you get is an onset of seizures between 6 months and 6 years of age, although it can be younger and it can be older. Then I guess a history of at least 2 seizures with 24-hour periods apart, and you have an unremarkable or completely normal neurological exam and general assessment, except for the post-ictal period, as well as the, let's say, side effects you get with drug administration, especially anti-epileptic drugs, can cause some side effects on your patients, okay? I guess the absence of any abnormalities in your minimal database and your blood work as well, a urinalysis and advanced diagnostics to rule out any toxic or structural brain disorder. So idiopathic epilepsy confidence levels. Idiopathic epilepsy tier levels according to the 2015 Epilepsy Task Force. You've got 3 tiers, and it's a bit like stacking clues, from educated guess to heartproof. Your tier 1 is the basics, so the lowest of confidence. And this is when you have your history, so 2 or more unprovoked seizures, more than 24-hour apart, with an onset between 6 months and 6 years of age, your normal neurological exam, and a clear routine blood work and urine tests. Then your tier 2, digging a bit deeper. This includes all of the tier 1 with a bile acid stimulation test, a brain MRI, and spinal fluid analysis that is normal. And finally, your tier 3 is the highest level of confidence, which is all of the above, plus an EEG showing seizure activity. So referral diagnostics, tests that we offer here at the hospital include advanced imaging of the brain, as well as cerebrospinal fluids analysis, electrodiagnostic tests, and infectious disease testing, especially for protozoal diseases like Toxoplasma and Neospora. I think, especially if the neurological exam is abnormal and the signs are asymmetrical, yes, referral is recommended. If the exam is completely normal, then things get a bit trickier. I guess there is no black or white in this matter. And I think in these cases, it's not unreasonable to hold off from referral initially. But I guess there is a few things to consider. A good rule of thumb is when approaching a dog with a first seizure, I guess to consider all of the things that I've told you already. So is this dog between 6 months and 6 years of age? And then I guess is this dog's or cat neurological examination normal? So there are 2 studies worth noting. The first is using a low field MRI, and this was done some time ago. And they found that around 2.2% of dogs in this age bracket, so between 6 months and 6 years of age, had anything structurally wrong with their brain. And the second study is using a high field MRI, and the number reported is even lower, with just 1.6%. That said, idiopathic epilepsy can still occur outside of the textbook age range. And also structural disease can happen in younger dogs and older dogs, as well as within that bracket. So I guess if you don't opt to pursue imaging, that's absolutely fine. But just make sure that you've ruled out all your extracranial causes. So go back to that table, make sure that you've done all your broad work. And I think things that make me think, right, I think this dog could be referred now for further diagnostics, is that if the animal is having seizures more frequently, if they occur in clusters or they escalate to status epilepticus, if the animal responds poorly to medication, or if there is new neurological signs that hadn't been reported before. So treatment for epilepsy. Idiopathic epilepsy is a lifelong condition and there is no cure, but in most cases it can be managed quite well. I think setting the expectations initially to the owners is really important. The aim is not to eliminate the seizures altogether, but actually to reduce the frequency and to blunt their severity so they can be a bit easier for the owners and the patients. So even on treatment, we're still going to have a seizure every now and then. We generally hope to halve the number of seizures, and I guess to make every episode at least less dramatic. Around 1 in 3 dogs will eventually require more than one medication to keep things under control. And we usually start treatment if there's been more than 2 seizures in a 6-month period, okay? If the seizures are particularly severe, or if they occur in clusters, or if the pattern is getting worse over time, or if there is an underlying brain abnormality known to be driving the seizures, these are all valid reasons for why I would start anti-epileptic treatment in my patients. There is a wide range of anti-epileptic drugs, as you may know, and sometimes it can be a bit overwhelming. Where should I start? What should I use? What's best to give the patient? So I guess there is no single drug that is clearly superior, so you can take a deep breath and just have a look at things that we consider. And I think the first thing is licensing, and this often guides our choice. So I guess in terms of licensed drugs in the UK, for dogs you've got phenobarbital and imipetoin, and for cats you only have phenobarbital. I think with these drugs, just consider the pet's needs, the owner's lifestyle, the factors like how do the drugs work, are there any side effects, do they need blood work to follow up on, is this animal got any liver disease already, and just get familiar with these medications. Adjunct drugs that are licensed in the UK is your potassium bromide, only in dogs. Just remember, please, that in cats, potassium bromide is dangerous to use. Other anti-epileptic drugs available are, we've got levetiracetam, zonisamide, topiramate. You've also got your gabapentin and pregabalin, but these are all used off-label, okay? So phenobarbital works primarily by enhancing the effect of GABA receptors in the brain, which is the main inhibitory neurotransmitter. And your initial dosing recommendations in dogs is slightly higher than cats, but in both is given twice daily. And you do need to check your serum levels 3 weeks after starting the medication or 3 weeks after changing the doses. And you need to use plain tubes, no gel. And what you're aiming for is to get at least serum levels between 14 and 30, but we personally find that often between 25 and 30 milligrams per litre are needed for good control in seizure activity. Levels above 30 milligrams per litre add very little benefits, and they can increase the risk of hepatotoxicity, so I would never increase further than that. And just be aware that you need ongoing monitoring. So you're going to be seeing these patients back for blood work more or less every 3 months, then every 6 months, and then every year, maybe every 6 to 12 months thereafter. Imipetoin works by targeting GABA receptors as well, so just keep that in mind. And it reduces sort of neuronal excitability and seizures. Now, the initial dosing recommendations, you've got quite a big gap, so from 10 to 30 milligrams per kilogram twice daily. And these doses can be titrated up slowly. You don't need any blood work at all, as opposed to phenobarbital. And I suppose this is something that owners might find appealing with imipetoin. You can mix imipetoin and pheno, even though they work very similarly. So if you start with imipetone, for example, and you find that you've reached your maximum dose and the dog's still seizuring, you can actually go on to adding phenobarbital on top, or you could potentially try phenobarbital instead, depending on the case, particularly, okay? And then potassium bromide. So I guess the benefit is that while phenobarbital enhances GABA receptor activity as well as imipetone, by sort of prolonging your chloride channel opening, potassium bromide acts as chloride substitute, and it hyperpolarizes neurons by directly entering chloride channels. And so ultimately is raising the seizure threshold via a slightly different pathway. It is a good add-on for phenobarbital or imipetone as a complementary action. And I guess one thing to bear in mind is that it takes up to 3 months to actually start working properly and reach a steady state in blood. So if you've got a patient that is having a high frequency of seizures or clustering, you might want to consider a loading protocol. I always recommend doing a loading protocol in the hospital because pets can get really sedate, and so close monitoring is advised. You do need to do blood work for these patients. So once you've done your first set of bloods at 3 months, then similarly to phenobarbital, you can check them every 6 to 12 months, along with blood cell count and biochemistry. Another tip for you is that remember potassium bromide is generally a salt, and so if the dog ingests any salt by accident, so for example by drinking seawater or by being fed very salty human food, potassium bromide levels can drop in blood, and these can actually lead to an acute onset of seizures. So I always ask my clients when they bring in patients that have had an increased frequency or a cluster, if there was any sort of changes in the diet of the pet if they're in potassium bromide therapy. So about 20 to 30% of dogs won't respond well to anti-epileptic medication, and sometimes just nothing seems to work. So I think before rushing into swapping medications around, adding more medications in, I think I would always go back to basics. So confirm your fundamentals, which is check drug compliance with the clients very thoroughly, and ensure that either phenobarbital or potassium levels have been recently checked and there are steady levels. And I suppose a vital tip as well is that, as I said earlier, salt exposure can sort of change or influence bromide levels. So take a bit of a history and see if anything could have potentially altered the efficacy of your treatment. There is no clear winner for a third-line agent, but it is sensible to pick a drug with a different mechanism to GABA. Levetiracetam is generally well tolerated by animals, although can cause side effects of sedation as well as changes in behavior, aggression, but generally it's a good drug. And I think the only thing I would like you to be aware of is that it has a bit of a honeymoon effect, in that the benefits of the drug are seen within the first few months and then they start to fade off and it becomes less effective over time. So rather than having levetiracetam as a drug long-term, try to use it for your cluster seizures. It's really good at acting quickly, and you can use it as pulse therapy for like a 48 to 72 hour window until the seizures are under control, and then you can actually safely remove the drug without needing to taper it off and keep it to the side. The owners can have a stock of it at home for these events, and that sort of helps the patient from going into a sort of vicious roller coaster of clusters or a status epilepticus. That said, there is no strong evidence that levetiracetam is better than other drugs such as zonisamide, topiramate, so there is definitely other options to explore in terms of adjunctive medication. I think in terms of the animals that are already on 3 or 4 medications for seizures, other things that we can consider are the vagus nerve stimulator therapy, which I will talk about in my next slide. So owners may ask you, is there anything else we can do? Unfortunately, we're a bit far away from therapeutic surgical intervention, but VNS therapy has actually shown good benefit in the study I've sort of posted here. So VNS stimulator is basically a stimulator that is placed surgically onto the dog's neck, and it stimulates the vagus nerve, and it sends impulses through the nerve, boosting neurotransmitters such as serotonin and noradrenaline, and it helps reduce seizure frequency and severity. It can act on a constant basis, but you can also sort of with a remote control ask for impulses to be sent in the event of seizure activity. The effects build over time, and it's most suited for dogs that are well controlled but are already on quite a few medications, and is something else to try. If you're wondering whether you could refer your patients for VNS placement, just you can refer them to Langford, where we do it here. And if you have any questions, you can actually access or visit our website, where you will get more details about these VNS implants. Around 40% of cats with idiopathic epilepsy become seizure-free on treatment, and another 40% will show marked improvement, with only 20% of them potentially becoming treatment resistant. So cats with seizures and no other neurological signs can still have a very good prognosis and behave similar to dogs. Phenobarbital is generally quite effective, and typically, as I said earlier, we start with a bit of a lower dose. And other drugs that we may use in cats include levetiracetam and gabapentin. Remember that potassium bromide poses the animal at high risk of fatal pneumonitis, and so do not use potassium bromide in your feline patients. Other conditions that may be worth mentioning, there is syndromes that may present purely as seizures and have variable sort of prognosis and treatments. Include, for example, limbic encephalitis, or also known as complex partial cluster seizures, which is a sort of suspected immune-mediated condition, which also involves orofacial involvement, focal seizure activity, but behavioral changes as well. And it tends to be quite severe and quite refractory to treatment sometimes, not always. And then, for example, feline autogenic reflex seizures is another thing to consider in terms of conditions that can cause seizures in cats. What the exact cause for, call it FARS, is unknown. There is a suggested inherited component, and animals typically develop FARS around the age of 15, with approximately half of these patients being completely or partially deaf. So the treatment goals are the same. We try to obviously prevent a high frequency of seizure and obviously cluster and status epilepticus. I guess to conclude, if you have an epileptic case, have a look at these resources. As I said earlier, they're free for all, open access, and they've got some supplemental material attached to them with doses of drugs. They're really useful, and they will help you not only with treatment, but also with, I guess, considerations and the diagnostic approach for your seizuring patients, and can maybe help improve the outcomes of your patients. I hope you found this lecture helpful, and please don't hesitate to put any questions on the comments below.